Hello and welcome everyone. My name is Richard Levin and I'm going to be talking to you all today about BPH, or enlargement of the prostate. I recognize a lot of people out there, so hello everyone. Some of you probably know a little bit about this procedure already, and hope to enlighten a lot more of you about it this evening. So first of all, I'm a urologist. I've been practicing urology now for 26 years. And it's been an interesting change in urology over the last 2.5 decades in how we treat enlargement of the prostate. I've seen a significant change in how we treat BPH, enlarged prostate, over the last 25 years, and it's been very interesting in that the procedures that we do for enlarged prostate have gotten less and less invasive over the years. It used to be there was a procedure that patients like to refer to as a Roto-Rooter job, and that was really the TURP, the transurethral resection of the prostate, which was the gold standard of treatment 20 years ago. It was a very good procedure. It still is a very good procedure, but I haven't done one in about 10 years because there's newer, less invasive things that have less side effects. And so I'm going to be talking about one of those today. But first I'm going to go through a little bit of background about the enlarged prostate and things related to that. So first of all, the prostate, for those of you who don't know or don't have one, it's a little gland that sits below the bladder, and its purpose in life is really to make the fluid that you ejaculate so that the sperm can get to where they need to go to get a woman pregnant. So after you're done that part of your life, the prostate really does you no good whatsoever. And in some men, it tends to cause problems as we get older. So that's kind of what we're going to be talking about. Here's the bladder. The urine flows through the middle of the prostate and then out the urethra. So what is BPH? BPH is actually enlargement of the cells of the prostate, but they actually only enlarge in a certain part of the prostate. And unfortunately for men, they enlarge in the part that the urethra travels through. So in other words, when they enlarge, they tend to close off the flow of urine. So a lot of patients come to me and they tell me that they have an enlarged prostate because their internist told them so. And they told them so because when they did a prostate exam, they feel the prostate and it feels enlarged. Well, that's interesting, because just because the overall size of the prostate is enlarged doesn't necessarily mean that it's causing any blockage. And I have a lot of patients that have a quote-unquote enlarged prostate, but the urethra is actually fine and they're not having any problems. Then I have some patients who the overall size of the prostate is actually quite normal, but they have a lot of problems because the tissue in the middle is being blocked. So that's what we're going to talk about. This problem, the enlarging prostate, is very common. 12 million men in the US and 790,000 new men each year. What I like to tell people is that by the time you get to be about 50, about 50% of men are starting to have some symptoms or signs of an enlarged prostate. And then as men get older, it tends to go in percentages. When you're in your 60s, about 60%, 70, 70%, and 80, about 80 to 90% of men are having some issues with the prostate. So what are the symptoms? Well, you guys could probably tell me what the symptoms are. So basically, it's the frequency of urination, can be either day or night. The urgency, meaning when you gotta go, you really gotta go quick. Difficulty to get the flow started. I have some patients who tell me, "Doc, I stand there for 5-10 minutes before things get going." Having to push or strain to get the flow going is not uncommon. Having a very weak flow of urine that takes a long time to empty the bladder, and actually not emptying the bladder completely is a problem. And then also this dribbling afterward, which we call post-void dribbling, which men tend to have a little bit of leakage after urination. So how do we figure this out? How do we determine what's going on? Well, there's a lot of different ways we do this. Patients of mine are probably very familiar with the questionnaire that we ask about your urinary symptoms, and we ask you to grade them on a scale of 0 to 5. And that score gives us a score to tell us how severe the symptoms are, all those symptoms that we just talked about. Additionally, we sometimes like to visualize the prostate. We do a procedure called a cystoscopy, where we put a flexible fiber optic telescope in through the urethra channel and I actually look at the prostate to see how much of that tissue has grown and is causing the blockage. We check to see how much urine is left in your bladder. We do a little scan of the bladder sometimes to see how much urine remains in the bladder after you urinate. The flow rate, we sometimes measure. We have you urinate into a special machine that tells us how much blockage there is of the flow. We measure the prostate size. Again, size doesn't always matter in this case. And the symptom score, the symptom severity is what I was mentioning previously. So what are the treatment options? There are a lot of options that go from less invasive to more invasive. Some of the options, like behavior modifications, that we don't actually have to tell people to do, they just kind of do it anyway. When you're, gonna go to a movie, people tend not to drink very much beforehand, or a long plane flight or a drive. People kind of tend to know that, you're not gonna drink a lot before that. So that's called behavioral modification. There are medications. There are two different classes of medications, types of medications, and a few different medications in each class. They've been around for 15, 20 years or so. There have been some newer ones over the past 5 years, actually probably not a new one in the last 5 years. And the medications do work for a lot of men. I often would recommend that men start with medication, so at least they know how bad they are. In other words, some guys, these symptoms have been going on for so long and come on so gradually that people don't even realize how bad it is. They take a medication and they think, this is what it's more supposed to be like. So the medications actually do work probably for about 70% of men. But typically, as the prostate continues to enlarge, the medications tend not to work so well anymore. Also, I would say a good 30 to 50% of men have some side effects with these medications, that some are not so bothersome, but some are very bothersome and not very desirable. So a lot of patients who try the medications that either work, but they don't want to be on a medication for the rest of their life, or don't work and they want to do something to improve their symptoms, there are other options. In the past, there were really some surgical procedures. The TURP is what I mentioned before. That was the gold standard. It does work, but it has a lot of side effects. After that came lasers. We do use lasers to open up the channel. Again, it works, but it has some other side effects. This also requires being asleep. The laser procedures and the TURP require being asleep. So kind of in between the medication therapies and the surgical therapies, there have been developed over the last couple of years a couple of different therapies that are kind of in between those two extremes. Work a little bit better than the medications, are a lot less invasive than the surgical therapies, and have less side effects. So I'm going to talk a little bit more about this one particular procedure, Rezūm. I've been involved with this procedure for about 4 years. I was involved in one of the first clinical trials that was done in the US. It was done at 10 different sites around the country, and I was one of the sites, and accrued, I think, one of the most patients in the study. So anyway, we did this study, and the results were very good, and the FDA approved this procedure about 1.5 years ago, very, very quickly. So the procedure was approved, is FDA approved, is covered by insurance companies starting in November of 2015. So for 1.5 years, we've been able to offer this to our patients commercially, not in a clinical trial. What is Rezūm, or water vapor therapy? So basically, what it does is we use a few drops of water and heat that to steam. And we use the steam to deliver the prostate to use the energy that is created when the steam goes from the vapor phase back to the liquid phase. And if anybody knows anything about the laws of energy, when you convert steam back to water, it releases a lot of energy. It's 540 calories per gram of water, which is a lot of energy. A lot more than if you were to just take water and cool it from, let's say, 99 degrees Celsius to 98 degrees Celsius, taking it from steam, which is 100 degrees Celsius, down to water at 99, it releases a tremendous amount of energy, and that energy is absorbed by the enlarged prostate tissue. And that actually treats the tissue.
Rezūm uses the natural energy stored in water vapor, or steam. It is a safe and effective treatment available to relieve symptoms associated with benign prostatic hyperplasia, or BPH. During each 9-second treatment, sterile water vapor is released throughout the targeted prostate tissue. When the steam turns back into water, all the stored energy is released, causing the cells to die. Over time, your body's natural healing response removes the dead cells, shrinking the prostate. With the extra tissue removed, the urethra opens, reducing BPH symptoms. Most patients begin to experience symptom relief in as soon as 2 weeks, and maximum benefit will occur within 3 months.
So the benefits are that it's an alternative to medication and an alternative to surgery. I'd say about 20% of patients get improvement right away, 25% of patients it takes a few weeks, and about 30 to 40% of patients it takes a month or two to see the improvement. It is a very simple procedure that literally takes me about 3 to 5 minutes to do. It doesn't require general anesthesia, so it can either be done under a little sedation, sort of like a colonoscopy, or it can be done completely awake. I do 73% of all of the ones I do with patients completely awake. They come in, they walk out, they can drive home if they want. It typically does not cause any changes to erection and to other sexual functions, which some of the other procedures have a higher likelihood of doing. So one of the big side effects with these types of procedures is something called retrograde ejaculation, where when you ejaculate, no fluid comes out. And that is a side effect of the TURP procedure about 100% of the time. With the newer procedures, the laser procedure that I mentioned, it's less than that. It's about 40 to 50% of the time. And in the clinical trials with this procedure, the Rezum, that retrograde ejaculation was about 5 to 6% of the time. So it's much less for patients who are concerned about that. And as far as getting back to regular activities, yes, most of my patients get back to pretty regular activities within a couple of days. Some patients actually the next day. They say about 2 hours of total time. I don't know about that. I would say that if that's the case, half of it is spent doing paperwork, probably 5 minutes doing the actual procedure, and maybe another 10 minutes of me talking to you afterward. The procedure, again, it's 9-second treatments of delivering the steam. How many treatments depends on how big the prostate is. So if you have a small prostate, it's probably 2 or 3 treatments. I'm talking treatments meaning 9-second treatments done at that same time. If your prostate's very big, it might require 8, 10, or 12 treatments. Some patients have to have a catheter. A lot of patients go home without a catheter. And oral medications, some patients take a little medication to reduce anxiety beforehand if they're going to be awake.
You need to know where every bathroom is within a 5-mile radius of wherever you are. You know, I remember there was a time when we were in Spain and the people we were traveling with were saying, you know, he's always going to find the bathroom. And I always had to. I had pretty well was resigned to the fact that I would have to take medication forever. Well, first of all, it was really expensive. You know, even though I have Medicare Part D, it still was an expensive thing. Plus, you know, it makes you dizzy, and I'm not so sure I wanted all of that stuff in my body. And so then I made an appointment and said, you know, I've read your brochure and I'd like to consider this. So had a conference with the physician. And, you know, he didn't push me at all. He said, you know, I want you to think about this. And so, you know, I did that, went home. I talked about it with my wife, and I said, I don't see where this is going to lay me up. You know, this should be something that's going to work really pretty well for me. And so I went back to the doctor, made an appointment. And, you know, I don't think I was at the clinic for more than an hour. it didn't hurt. It felt weird, but it didn't hurt. I first started feeling relief from the symptoms probably 3 weeks after the surgery, because I had to gradually get off of the Flomax and start taking those pills every other day because you just can't stop with those for 2 weeks. And the Avodart, my urologist said, take it until it's gone. So when it was gone, I was free. Since my resumed procedure, I've been able to be free of having to know where the bathroom is right away. I don't have to take pills, and I don't have to pay for them. When I do get up at night, which is about once a night, and I think that's pretty normal, I'm not dizzy. I don't feel like I have to hold on to something. It just kind of really works beautifully. And there have been no side effects. My God, to have the freedom. This is really what has been the end result, is freedom. Freedom is a big thing. I would really say this sets you free. And when you're 75, like I am, that becomes a really important issue. I would say to my friends, and have, about the procedure, it's easy. And if you're thinking about it, do it. It gives you the freedom that you never thought you would have again.
Basically, it's a very good procedure. It's not for everyone. Certainly, you need to be evaluated by a urologist to determine if we think that it's a good idea, a good procedure for you. Some people with these symptoms, actually the symptoms aren't related to just the prostate, but there can be other issues as well. If you're not happy with the symptoms, you're not happy with the current treatment, medications, then certainly this is something to consider. So at this point, I think what I'll do is I'll take some questions. I also want to say that one of my patients who had this procedure gracefully volunteered to come here tonight to possibly answer some questions.
My name is Chris Hampson. I'm a delightfully young 68 years old. I had the procedure done a little over a year ago. I'd initially come to Chesapeake Urology, and I had an appointment with another doctor, and I was going to have the microwave procedure. And then he told me that Dr. Levin was involved with this recently approved procedure, which I had done. I had my yearly checkup 2 weeks ago, I think it was, something like that. Mine was more like the Goodyear blimp. I was in the 9. And I know on there that looks like, man, that's gotta hurt like hell. It doesn't. Doesn't hurt at all. And he's true about the procedure. If it was more than 5 or 6 minutes, I was trying to recall on my way over here how long it was, and I knew it wasn't long, but it had to be somewhere in that range. Before I had the procedure, I put up with the symptoms for probably a year. And the night that finally did it, I'd gone to dinner at a restaurant out at the White Marsh Mall. And before I got to McDonald's, I had to pull in a street, open the door, and go in the street. That's how good that was. I was going probably 10, 12 times a day. And one time, it always seemed to be the same, so don't tell my wife. I took a measuring cup, went in the cup, and it was 2 ounces. 2 ounces, 2 ounces, 2 ounces, 2 ounces, 2 ounces. After the procedure, he showed me how to use the catheter. I didn't need it. I really suffered no after-surgery pain. I went back to what I do 2 days later, and didn't really need the medication. And since then, there has been no backlash, no side effects. He knows what he's doing.
Were you put to sleep, or did you have sedated, or
No.
nothing?
So, and actually, believe it or not, when I did your procedure, I did a little bit different technique in terms of the numbing medicine. I changed that a little bit, and actually it's even less painful now than when you had it done. He asked that if you're getting these symptoms, is it possible to have prostate cancer? Yes, it's possible, but these symptoms are not specific for prostate cancer. So in general, prostate cancer has no symptoms, which is why we recommend the PSA blood test and the yearly rectal exam. So I kind of alluded to when I get patients that say their internist, did the prostate exam and said their prostate's big. I tell my patients, that's great, but that doesn't matter, because when I feel your prostate, I'm not feeling for the size. I'm feeling to see if there's any hard nodules that would indicate a risk of prostate cancer. But all these symptoms that we're talking about, they're not symptoms of prostate cancer. They're more symptoms of an enlarged prostate. And enlarged prostates, they're both have to do with the prostate, but actually they happen in different parts of the prostate. So prostate cancer actually happens in the very outside of the prostate, so that it's more likely we can feel it with our rectal exam. The BPH happens on the inside of the prostate, which is why when the prostate enlarges on the inside where the urine flows, that's why it causes these symptoms. So they're separate, and no, they're not related. Any procedure that we do, you might need another one done 5, 10 years down the road. My experience with the laser procedure, which we've been doing now for about 11 or 12 years, is that about 10% of men need something done between 5 and 10 years later. This procedure, the clinical trial now, the patients are, a lot of them are coming back for their 3-year follow-up, and they're still doing very well. So, will some patients need to have something done again? Yeah, probably, depending on if your prostate continues to grow. Now, there are actually medications we can put you on to prevent the prostate from growing, but I don't typically recommend them because they cause lots of side effects. Most of my patients come off their meds. And he was, if I look back at your chart, you were on the Flomax twice a day, and your symptoms were pretty bad, and now he's not on any medications. The rectal exam, again, primarily we're feeling for cancer. Once men get to a certain age, the studies show that prostate cancer is not going to cause you any problems because it's such a slow-growing tumor. So, yes, I often tell my patients that, I can forego that a very unpleasant test if you would like. But as far as the urination symptoms, again, that's a whole different aspect of the prostate. So most patients, if they can come off the warfarin, I recommend they come off of it. If they can't, I have done this procedure on warfarin. The patients that I do awake, I have them urinate right after the procedure. If they can urinate, then most of them don't need a catheter. If they can't, then they have an option of either having a catheter in for a few days or learning how to put a catheter in, which is called intermittent catheterization. And as Mr. Hampson told you, I taught him how to put a catheter in case he had any problems, but he never needed to do it. So some people get swelling of the prostate from the procedure, and it takes a few days for the swelling to go down. And some people it swells so bad that you just can't pee at all. So PSA is, for those of you who don't know, is a blood test that measures a protein that's made by the prostate. It stands for prostate-specific antigen. We use that to try to identify men that are at risk for prostate cancer. But it's not a perfect test, and some of the PSA is made by normal prostate tissue. So we're getting rid of some of the normal prostate tissue, and so the PSA therefore does tend to go down somewhat, a little bit. There are some medications some of you may have been on called Avodart and Proscar, and they really lower the PSA by 50%. This procedure, I haven't seen it that low. I've seen some patients who it doesn't go down at all, and I've seen some patients who it does come down some. But that's kind of I look at it, it doesn't really matter whether it does or not. I mean, it just is what it is. Now, to be honest with you, I have not done this, I've not needed to do this procedure twice in somebody yet until about a month ago. And that was a guy who was in urinary retention. He couldn't urinate at all. Typically, I recommend a more aggressive surgery for somebody like that, but his heart was so bad that he couldn't have anesthesia. So his only option was a procedure awake. So I did the procedure on him and a year ago, and unfortunately he still was never able to urinate. But he decided he wanted to try it again a year later. Well, guess what? This time he's urinating. So, well, the green light is the laser I've been referring to. That's a more invasive procedure. It has to be done asleep. I'm not going to say it's better or not better. Sometimes I recommend one to a patient, sometimes I recommend the other, sometimes I recommend, you could choose whichever you want. That procedure, like I said, has to be asleep. The chances of retrograde ejaculation are much higher, about 40 to 50% compared to 5 to 6%. So it's just different, and you kind of got to choose. With the laser procedure, the urinary symptoms tend to improve more quickly for some patients than they do with the steam, but for the steam, I think the average for the steam is probably more in the 3 to 4 week range of getting good improvement. And I look back at your notes, and at your 1 month checkup, you really didn't have much change. At your 3 month checkup, you were like amazed. So he asked, if this kills the cells of the prostate, what does it do to the cells of the urethra? And that's a very good question, and it does absolutely nothing. And the reason for that is, so the prostate has different zones, okay, different areas. And I already explained to you how the middle area where the urethra runs through is where the enlargement occurs. So here's the middle area is where the enlargement occurs. The outside area is more where the cancer occurs. So what we do is the needle penetrates into this area that is where the enlargement occurs, and the steam is released directly into that area. The steam is water vapor. So if you breathe, okay, onto your hand, okay, your breath is not going to go beyond where your hand is, correct? Because there's a barrier. Well, the same thing with the prostate. There's a barrier right here between the prostate and the urethra. And so that steam stays in this area where the enlargement is. It doesn't actually go into the area where the cancer is. And actually, this treatment, I don't know how much I'm allowed to talk about this, but in the future, this treatment might be used for prostate cancer by injecting the steam into different zones of the prostate. So basically, it's because of it's called the zonal anatomy of the prostate that the steam stays where you put it. And we put it in the area where the prostate's enlarged. So these little puncture sites heal within a day or two. Yeah, the water just gets resorbed by the body. And it's actually, so do you know what a milliliter is?
Pretty small.
Pretty small. So each steam injection is 0.42 milliliters. So it's not very much volume. Each injection is a different area in the prostate. There are different modalities for treating this problem, and some doctors have decided to, just do one or the other. It's really not a very difficult procedure compared to some of the procedures that we do, so it's very easy to get trained in if somebody wants to. But, it's just like anything else. You kind of do what you like doing. They're all procedures that work, and it just depends on the individual patient, what the prostate size is, what the important factors are to that patient. So this first study was done with prostates from 30 to 80 grams, which is, an enlarged prostate. They're planning on doing an extra large prostate study from 81 to 150 grams. The largest prostate I've done personally is 151 grams, and he's doing very well. Currently, it's not designed to treat cancer cells. But certainly if the steam hit a cancer cell, it's going to get rid of it. It's going to destroy it. But again, like I said, most of the time the cancer is in the outside part of the prostate and the enlarged prostate is in the middle. And they're doing studies right now actually outside of the US in prostate cancer with this. I think that, a couple patients have had some difficulty urinating for a little bit longer, a few weeks, a few. I've had a couple of patients who didn't get the improvement that they thought they would, but I'd say 90+% do. So yeah, there's nothing that's perfect, and so yeah. But there have really, to my knowledge, have been no. The most serious side effect that there is that it doesn't give you the improvement that you thought it would. There's been really no bad side effects. No serious complications with this procedure. I don't believe anywhere. Well, like I said, the gentleman who asked about the Coumadin, I would prefer that patients stop their blood thinners, but I have done this procedure with patients continuing blood thinners. There's just a little bit higher risk of having some bleeding, and patients do have some blood in the urine after this procedure, which typically doesn't cause any problems. I'm sure you had some blood.
One time.
That's it?
Yeah,
One time?
The one that I recall, because
Okay.
it looked more like grape juice, or there might have been a few drops later on, but I didn't believe that much.
Okay, I mean, typically patients have a little bit more blood than he's describing. You know, a little blood in the urine on and off for a week or two is pretty typical. Somebody on blood thinners, it might be more than that. There's a correlation between the size of the prostate, which increases the number of treatments, which I think increases the need for the use of a catheter. Some men prefer to have a catheter and learn how to insert it themselves if they couldn't urinate, and that's called intermittent catheterization. There are other men who don't want to mess with that and who just want to leave a catheter in for a few days. I teach people how to do whichever they're more comfortable with. I think that the differences in effect are minimal, and most people don't notice much difference between Rapaflow and Tamsulosin or Flomax, but I'm not opposed to it. I mean, I don't ever push anyone toward having a procedure. Patients come to me and say, all right, I'm ready to have this done. I give the options, I talk about it, but I don't ever tell someone, okay, you know, we really need to do this procedure now. I don't do that, unless it's for cancer. But if it's for something like this, patients tell me when they want to do it. If you want to try another medication, sure. All right, well, I really do thank everyone for coming. I really appreciate it. Hope that we learned something.